We are live.
So good evening, all the All India Ophthalmological Society members and all the viewers, and a happy New Year, as well as a happy Sankranti, happy Bihu, happy Pongal to each one of you who are attending this particular webinar. So today, on behalf of All India Ophthalmological Society Academic and Research Committee, we will be having this monthly webinar, which is going to be a subspecialty base, that is going to be oculoplasty. Basically, the theme of this particular webinar is rebuilding form, reviving functions, a game-changing approaches in oculoplasty. This webinar is basically aimed at comprehensive ophthalmologists so that they can learn from this particular webinar small tips and tricks, and they can emulate them in their day-to-day clinical practice. I'm thankful to Dr. Usha Singh ma'am and Dr. Lakshmi Mahesh madam for chairing this particular session. And of course, our star faculty and star ARC member, Dr. Kasturi Bhattacharjee, for wonderfully crafting and getting this constellation of all oculoplasty speakers today for this webinar. So without much ado, can I request Dr. Kasturi, ma'am, our member ARC from East, as well as the moderator for today's session, to carry forward the proceedings.
Thank you, Dr. Prashant, for giving the OPAI, the Oculoplastics Association of India, to be organizing this lovely webinar on basically a theme, which is very interesting theme. And today we are really going to see some game-changing approaches in oculoplasty, both in surgical and non-surgical field. Very much honored to have here Dr. Lakshmi Madam, who is a teacher of teachers, who is a mentor for all of us, the past president of Oculoplastics Association of India, and who's a very learned academician and a great oculoplasty surgeon to have with us today as a chairperson. And I have no words how to introduce Dr. Usha Singh. She needs no introduction. Being the professor of a very renowned advanced eye care center, the PGI in Chandigarh, she has done extensive work in ocular oncology, mainly retinoblastoma and also oculoplasty surgery. Recently, in January 2025, she had received the Distinguished Professors of India Award by the 40, reviewer of multiple national and international journal, and also she had received the best paper of best poster of the European Society of India and also the ISU. And I've got no words. She's doing lots of philanthropic work, and she goes to Bangalore and many places as to do her free surgeries and the free treatment. Usha, we are so proud to have you with us today. And without delay, let us start the session. So the first topic will be presented by Dr. Usha Singh, and she'll be showing us some interesting and challenging ptosis surgery from the basic to the advancement, mainly to the frontalis flap. So over to you, Usha.
Good evening, everybody. Am I audible?
Yes, ma'am.
And I'll straight away go to the talk. But before that, I would like to thank Dr. Prashant, Dr. Kasturi, Dr. Lakshmi Mahesh. And thank you, Kasturi, for that extensive introduction, though I feel I'm just one of you and all of you are achievers in your own way. So I will go to my talk, and the talk for today my talk is on challenges in ptosis repair to frontalis advancement. Please excuse my throat because I have a bad throat. So coming to the complex ptosis patients, they are a group of patients with wide range of underlying etiologies with associated ocular and or systemic conditions and previously failed ptosis surgery to the patient's satisfaction. Surgery for blepharoptosis, it's a complex and nuanced surgical procedure. Hence, it needs an expert to do all these surgeries, especially the revision surgery. It's always a challenging one because the final result is based on what exactly was done previously and how each body heals afterwards. Removing scar tissue to achieve a natural look is always the goal, but every eyelid behaves differently. So it's not always possible to get as much lift as or symmetry as we hope for. Just a second. So the challenges come with the complex ptosis, and it's multifactorial because there are different mechanisms at play. And the final outcome will be is dependent on many of these conditions, the severity of the condition, patient's age, and underlying cause. So some of the ptotic eyelids with strabismus, hypertropia, absent bells, dry eye, absent corneal sensation, and Marcus Gunn phenomena. These are the complex ptosis with the. Then we have this involutional ptosis that's also a complex repair, requires a repair, and neurological ptosis such as CPO, ptosis with floppy eyelids, post-ocular surgery uh, following squint, glaucoma, or RD surgeries. Resurgeries is often required in 28 to 30% of the patients, especially after congenital ptosis repair. And post-traumatic ptosis, these are the real challenging ones. Now let's go to the first patient, and this patient had all the, uh, you know, surprises, challenges, and it's like a roller coaster ride for this patient. So this is a 24-year-old patient. He had ptosis since birth, bilateral. And in the right eye, it was severe, and in the left eye, it was moderate. And he gave history of ptosis surgery in 2018 by plastic surgeon, and they had done a bilateral FOOM. So FOOM surgery is, as we can see over here in the right eye, the LPS action just 4 to 5 mm, and the left eye was 9 to 10 mm. And you can also see that the skin is irregular and lid margin is irregular, and there's no lid crease in the left eye. There's a faint lid crease, plus there's a scar in the left eye, upper lid. And he had a very strong frontalis muscle action, and he was unable to relax despite our this thing. So now this is he carried these notes. So you can see from the diagram that frontalis muscle and the orbicularis muscle, they've been made into a sling and attached to the tarsal plate. So this was a term put forward by Lai et al. In 2010, and it refers to the interdigitation and cross-linkage of the horizontally oriented orbital orbicularis oculi muscle fibers and the longitudinally oriented frontalis muscle. So you can we'll just have a look. Despite our he was still using his frontalis muscle. It's very strong, and so finally he was taken up for surgery. And you can see that this is the first stage. We planned for the right eye, and you can see the right eye that LPS resection was being done. And I thought, let me give a advantage to this patient, since it is 4 to 5 millimeter, let's do LPS. And there was a lot of fibrosis, and tissue planes were not clear, and there was but still I persisted, and we can go ahead, and you can see a lot of irregularity, margin, and this fibrosis over here. So fine. Oh, sorry. Let me just go back. Oh, yeah. Anyway, I think we got a good correction in the right eye. There's a photograph which is overlapping the right eye correction. So this was it was fairly acceptable, this correction in the right eye, considering that the LPS action was just 4 to 5 millimeter. Finally, we thought we'll just go ahead and do the left eye LPS resection. And you can see there's a thick band over here. There's a scar, and there's no lid margin, and the lashes were downwards. Okay. And when we inverted the lid, you can see the suture hanging over there. There was a silk suture which was on the undersurface. And when we open it, you see all this fibrosis. The tissue planes are not clear, and there's a lot of fibrosis. And here you can see that horizontal fibers are there, and there's a skin pucker over here. So anyway, we dissected this muscle from the LPS. And again, this was everted to see the tarsal plate. And you can see the tarsal plate is not smooth at all, and it's full of fibrous tissue. And so we had to excise all that and clear it up. And this is the good correction that we got in the left eye. So at this time, the patient said, "Why can't you lift my right eye again?" He said, "I would like to have it corrected." So I just reevaluated. Now, after seeing initial LPS action was just 4 to 5. So when we did the uh, assessment of the LPS, you can see it's easily about 9 mm, 8 to 9. So I said, wow, that was good. So maybe our surgery had realigned all the fibers and also, and his LPS action had revived, had returned. So we went ahead and did the right eye surgery. So this is the correction we got on the table. And you can see this, there's a good correction on both the sides, and he was a very happy man. So the surgical tips for revision is previously failed surgery, in previously failed surgery and post-traumatic ptosis cases. So in pre-op period, we need to assess clinically thoroughly. We have to keep measuring LPS action repeatedly on different occasions and also just before surgery. And all these patients need detailed counseling, even and also make them aware for a small amount of uncertainty. Eyelid crease incision is preferred in these patients where resurgery is being done. And we choose an eyelid crease. We try to make an eyelid crease if it is not there. And however, exercise caution because we should not be excising too much of or sacrifice too much of tissue. So only the minimum possible. And we have to be prepared for surprises, as in one of the cases I had found steel sutures. Intraoperatively, we do surgical procedure under microscope with fine forceps and instruments and do small steps causing minimal manipulation of the tissues and identifying each and every tissue. Then examine anchoring site and examine LPS for holes, tears, slippage, loosening of anchoring sutures. Free the tarsal surface of all fibrotic tissue. Remove old sutures, scar tissue till there is no pucker or traction on the muscle. Compare with the other eye and adjust height of the anchoring suture if high or low. And post-operatively, we give them analgesics for pain, antibiotics, or antibiotics wherever required, post-traumatic cases, ointment for the night, and lots of ice fermentation. This really helps avoid weight lifting and avoid injury. This is a standard instruction for all my patients. And here is a patient who had post-traumatic ptosis repair, and this is quite a lot of edema and all, but she recovered. She recovered a complete contour and lid height with time. So following all those principles of repair, we can do correction in most of these other cases also. So here is a patient with blepharochalasis, and blepharochalasis, they have this loose, thin skin, stretched skin. So this is a periodic, episodic, inflammatory edema, painless. It occurs in young people, and then it slowly, as the patient grows with age, and it seems to settle down. And here is a young lady, 24 years, and she had recurrent episodes of swelling for 6 years, and she really wanted. She was a professional, young professional, and so we did skin excision for her, and this after skin excision, we have done the LPS resection, something like a epineuritic surgery we do in senile ptosis, and that advancement was done. And so only thing we have to be careful is not to overcorrect. So we can see the correction achieved on the table, and she did well. So here is another patient. Here is a young patient. She's undergone a filtering surgery, and she had a large bleb as seen over here. And she also achieved good correction after surgery. Now, coming to this chronic progressive external ophthalmoplegia, which is a kind of mitochondrial myopathy. And this lady, she's an 80-year-old female. She had all the elements. She had loose, thin, stretched skin, ptosis, restricted extraocular movements. She had multiple systemic conditions also, like Raynaud's, hypertensive. She had oculopharyngeal dystrophia, hearing loss, and so finally, and she had a family history. She had many members in her family with the same problem, the CPO. We had advised her genetic testing, but they refused. They knew that it was a genetic and hereditary one, so they refused to undergo this. So we did a bropexy, and in bropexy, it was this has to be done with a lot of caution, as the BELS was very poor, and I was very, very conservative. And first, after bropexy, I've done blepharoplasty, remove the little bit of the skin. and planned undercorrection with minimal LPS resection. And that is how she was managing with this. So this is her son. This is this patient's son, and he had the same problem. You can see he was living in the hills, so he had difficulty in driving up the hills. You know, he had initially when he was young, he didn't have much problem, and this is how he looked when he was young. He was fairly okay, and so, and when he came to us, he was 57 years old. And in all these CPO patients, surgery is the choice. And so we plan to do sling surgery and we plan undercorrection. So this is how he looks in undercorrection. But he was fairly satisfied because both his axis was clear. And this is his mother's photograph, who was still, she was using this crutch glasses. Now coming to the frontalis muscle advancement, frontalis muscle flap advancement is a surgical technique that is used to treat severe ptosis with poor LPS function. Here, there is a direct transfer of power. It involves a transferring power from the frontalis muscle to the tarsus to elevate the eyelid. As you can see in this diagram, the section of the muscle fibers have been pulled down and sutured to the tarsal plate. So here, now this is a young girl who had failed, she had undercorrection after sling surgery. You can see the scars on her forehead. And this is the surgery. So orbicularis fibers have been separated, and I have identified the frontalis muscle over here going higher up. And you see, this is the orbicularis occlusi, this is the frontalis muscle, which is being pulled down. So we have to make a good separation. I separate both underneath and over. So we suture it, anchor it to the tarsal plate, just like how we do for LPS resection. But you can see I'm getting an overcorrection over here. So I loosen the sutures and reapply them. So we have achieved a good correction in this patient. And do we have time?
Yeah, I think lots of topics, like 10 minutes almost over. Can you just
Okay, so I'll just wind up. So here is another patient. We have got a slight overcorrection and we adjusted on the table and we got a good correction on the table. So coming to the conclusions, complex cases are challenging with heterogeneous underlying mechanisms. And we need to investigate these cases where there is a systemic element involvement. And preoperatively, repeated ptosis evaluation should be done and know when to undercorrect and when to overcorrect. Patient counseling in detail is important for pros and cons and should be prepared for minor revisions in the immediate post-op period. Despite the unfavorable situation of the resurgery in a setting of ocular diseases, good to excellent results can be achieved. And we should not give up even in cases who have been operated elsewhere. And, you know, like the first case which I have shown, that's a very good example. Even in the worst eye, the severe ptosis eye, we could get an excellent correction. And frontalis muscle advancement is a game changer. I've stopped doing sling surgeries in these patients with poor LPS action. And so far, so good. I'm getting good results. Thank you with this.
Thank you, Dr. Usha, for that excellent presentation and showing so beautiful, challenging cases. We have Lakshmi Madam here. Ma'am, would you like to add something who has tremendous experience in managing all these complex doses? Madam, are you here? Lakshmi Ma'am? We would like to hear some words of wisdom and from your experience. Can you add some points to it?
Thank you very much, Kasturi. Thank you all once again for the invitation. I think I learned from every case discussion and everything. Usha initially beautifully showed the intraoperative pictures of the first case. I think if you ask me, I get to do only complex ptosis cases now. I don't get very many fresh cases. Uh, all challenging ones only. Some of them are fourth surgery, fifth surgery. And you open them, sometimes I see a lot of suture granuloma. Now, having done of late, the last few cases, having done mainly complex cases, I think the main thing is we have to expose the site very well. Open up the whole thing. Please give adequate local anesthesia. And if the patient is under GA, it's fine. Even then, give local, and also give additional. If the patient is not fit for GA, please ask whether you can give monitored anesthesia, that is good sedation. They definitely need sedation when it's a re-op. And you have to just delineate the tissue planes very, very well. I think that's the key. And then you will be very surprised that sometimes you will have so much of levator at disposal, though it may have been a maximum excision. So I think adequate exposure and dissection is the key. Thank you.
Thank you, ma'am. And I think now we'll go to the next speaker. So Dr. Feroz will be giving the next talk. Her friend is having some surgery and she's still in the hospital. Like, I'll briefly introduce Dr. Feroz Manjan. She is the founder director of Horus Oncology and Oculoplasty Center at Bangalore, and she's a member All India Ophthalmological Society Academic Committee. Great surgeon, a very great academician with excellent work in ocular oncology. Besides being very dynamic and a beautiful personality, she is ever helping and is an amazing fitness enthusiast who's very passionate about physical fitness and health. Recently, she was the president organizing committee of ISU, which is the International Society of Ocular Oncology Conference at Goa. A very successful and a grand conference was organized under her leadership. So over to you, Feroz, and welcome you, and very happy to have you with us today.
Thank you so much, ma'am, for this kind introduction, and thank you for including me in this fantastic session with all the stalwarts in oculoplasty. And immense gratitude to Dr. Prashant and the ARC team for regularly conducting such educative platform for all of the AIOS members and otherwise. So the topic is pretty direct on eyelid tumors, which is again my field of interest. So I will be taking you through newer advances in eyelid tumors, preserving vision and structure, and that's exactly what Dr. Kasturi wanted me to speak on. So let's see what we can do. These are my affiliation and financial disclosure. So going on to the topic, well, there are newer advances. There are advances in eyelid tumors, be it benign or malignant, where we have been able to stride a little bit further from how, conventional treatment has been in kind of preserving the eye, preserving the structure, being very conservative and minimal in treatment. And we all, it's always good to believe that less is always more, and keep the structure intact and the function intact in these eyes, and it's always good to do that. So I will take you through few cases, which is a learning, and I'm sure every case is a learning from us. This was a 1-year-old child who was actually sent for a second opinion, where she was found to have this swelling in the eyebrow, and in fact, was advised a surgical excision. Well, so then, it is elevated. There is a soft to firm lesion in the eyebrow of this child. But what really caught my eye was this kind of reddish cutaneous discoloration of this particular lesion. So where I was kind of thinking in different terms of being very conservative and not going for a surgery. Now, seeing that lesion, what we went ahead doing was to examine the child overall, and there you see another reddish purplish lesion, a strawberry lesion in the neck of the child. We didn't stop there. So whenever we get multiple or even single, reddish lesion in anywhere in the face or the periocular area, it's very important to do a full systemic evaluation. And this is what we found. in the body of the child. This is the torso, back, trunk, where we found larger lesions sitting there. So this is a very straightforward case of, an infantile capillary hemangioma, where initially the the thought was to excise the lesion. Then second opinion came, and it revealed so many lesions in the body where we actually would like to go conservative. Now, earlier, conservative treatment was accepted in the treatment of capillary hemangioma in terms of oral steroids and intralesional steroids. But what came up recently, well, it's not too recent. There has been like multiple publication when it came, when it was accepted as a treatment. But well, most of the doctors are still little hesitant to use oral propranolol, but it is considered to be safe, conservative management in this. So this child received 2.5 milligram per kg body weight, and we tapered the doses in halves every 4 weeks. So this was 3 months post-treatment, where the lesion has completely disappeared from the periocular area, flatter in the neck, and much more flatter in the torso. And at 3 years post-treatment, it is almost faded. So this is what we have studied in the recent past, where conservative management in benign, vascular lesions of the eyelid. So this was again a 38-day-old infant who came with this very superficial lesion of infantile capillary hemangioma. We started the treatment with oral propranolol day 4, day 7, day 9, and day 30. And well, at 4 months, the entire lesion has disappeared. This child also, along with oral propranolol, since it was a superficial lesion, topical timolol maleate was also given, and with complete resolution. So infantile hemangioma, what is, what we currently use as a protocol is oral beta blockers, topical beta blockers, and even intralesional beta blockers has been reported. The mechanism of action is vasoconstriction and decreased expression of the vascular endothelial growth factor, the VEGF factors, and of course causing, final apoptosis of the capillary endothelial cells. We need a strict monitoring of vital signs and blood sugar. Initially, when we started using it, there was a little bit of fear in using in infants and children. But then over the time, we have recognized and realized that most of these side effects are not too common, although a pediatric consultation has to be taken. Now, importance of the indication and the period at which you should be using oral propranolol is during the proliferative phase, that is during the rapid growth during the first 4 weeks until 4 to 6 months. Later may not be helpful. And this was what changed. This was the first publication which came, and this is not really new. It came out in 2008, but recently we have all started using oral propranolol as a treatment of choice. 24-year-old lady with complaints of lower lid swelling, left eye, as you can see here, noticeable 5 years, and associated with aching pain. Now, whenever we see this purplish lesion in the eyelid, first thing that we would see is to differentiate vascular lesions from a venous malformation to an arteriovenous malformation or a venolymphatic malformation. So this is the Valsalva's test that was done in her, which increased the lesion, and this was diagnosed with the MRI that you can see here as eyelid venous malformation. Eyelid venous malformation, the other name is varix. We often find it very difficult to manage varix, and operating on a varix is very bloody. So what I used in this particular case was injection bleomycin. Injection bleomycin, again, although it is a conservative treatment for venolymphatic malformation, and it has been extensively used. In my practice, I have started using injection bleomycin even in varices, although we use very regularly in venolymphatic malformation, be it periocular, orbital, or even ocular surface. And this is actually one session and complete resolution of the lesion. So vascular anomalies, I'm not going into the details. So injection bleomycin and local treatment for these particular lesions is very much used in our practice currently. Now going on to eyelid tumors, well, I will, because of the paucity of time of 10 minutes and wanting to cover the whole subjects, I'll stick on to a few very important topics today. I'll directly go to malignant eyelid tumors. We all know that basal cell carcinoma, squamous cell carcinoma, sweat gland carcinoma, Merkel cell, malignant melanoma, and sebaceous gland carcinoma are the malignant eyelid tumors, where I would further subclassify into lethal eyelid tumors like Merkel cell, malignant melanoma, and sebaceous gland carcinoma, where there is a high chance of recurrence and also systemic metastasis. And these tumors are really, really taken seriously in our practice. So this is a 59-year-old lady who came with redness and discomfort for the past, this has been going on for the past 1.5 years, on topical eye drops, steroids, lubricants at various places, and still there was no resolution but progression. And there was, the treating doctor was not convinced about the diagnosis and was further referred to our practice. And this is what we saw, this unilateral kind of a blepharitis look. You can see a lot of discharge, and if you have a closer view, there is a lot of keratin deposition in the medial canthus, upper lid and the lower lid, extensive and diffuse condition. So what I went ahead doing was I was suspecting either a diffuse squamous cell carcinoma of the conjunctiva, or OSSN, or a sebaceous gland carcinoma. So this is how we take the map biopsy. In fact, she had a very nodular lesion in the caruncle, where I went and took a biopsy, and all these map biopsies came out to be positive as invasive diffuse OSSN, and the caruncle came out as invasive squamous cell carcinoma. Went ahead excising the whole caruncular area, but the diffuse dysplasia and OSSN was treated conservatively with cryotherapy, topical interferon alpha-2b, and injection interferon alpha-2b intralesional. So, this is how we go ahead doing intralesional interferon alpha-2b. I'm sure many of the ocular oncologists would be doing this regularly in their practice. And we balloon the entire conjunctiva, the superior bulbar and the 360-degree bulbar conjunctiva and the fornices. Now, what finally we could do was to preserve this eye. Otherwise, this eye would have gone for an exenteration. So there is again conservation of eye and vision here. Now, when we talk about malignant lesions and malignant tumors, we definitely apply the principles of oncology, where we actually want complete tumor control, mainly to prevent recurrence, regional systemic metastasis, and life salvage, especially in the lethal tumors. So surgically, we all know this is what we do. We need, frozen section margin control. This is also not new, but I would want to emphasize this here because, notably, most of the practicing ophthalmologist really doesn't follow the protocol. And this is, of course, a platform for me to emphasize the importance of this. And we do frozen section technique and Mohs micrographic surgery to get a margin control. And we believe it's very, very important in these cases. In sebaceous gland carcinoma, this was a recurrence 3 times where only excision biopsy was done without, getting a margin clearance. And there was a recurrence. And this is 3rd time that I was operating on her, and she completely had a margin clearance and without any recurrence. Now, there are situations where this may not help, where patients come with large tumors, where in fact, as an oncological principle, margin clearance is very, very important to prevent recurrence. So what we do is to chemo reduce the tumor to a size where when you finally excise, you get the margins clear. So there is initial chemo reduction with neoadjuvant chemotherapy. We use 5-fluorouracil and cisplatin. There are very few reports on this, but this is something that we regularly use in our practice. And then finally get a margin-free excision with preservation of this eyeball and the vision. Now, in squamous cell carcinoma, as in this case, where there is, extensive orbital extension involving the lower eyelid and upper eyelid, in this particular case of mine, I had to go ahead doing exenteration. But things have, and well, this is exenteration customized prosthesis. But well, we have come to an era where we have so many MABs and IBs and ABs, where you have immunotherapy and molecular targeted therapy, where we can kind of chemo reduce, use these drugs as chemo reduction in preserving the eyeball and vision. So in squamous cell carcinoma, although I didn't have access to erlotinib, afatinib, or cetuximab in this particular case, but then recently we have started using this along in collaboration with the medical oncologist, which is the epidermal growth factor receptor, which can be considered in these situations. So I don't have a personal experience with it, but this was the first paper that was published with by Dr. Bita Ismaili with reduction of squamous cell carcinoma. We all know about it, vismodegib, and the hedgehog inhibitor pathway inhibitor for basal cell carcinoma. Again, extensive tumors involving the phase or even the orbit can be treated. And this was the first paper that came across. Now, other checkpoint inhibitors like immune checkpoint, where CTLA4, PD1, and PDL1, targeted inhibitors are available. Most commonly, we have pembrolizumab, nivolumab, and ipilimumab, which is used in melanoma. But there are recent International Society of Ocular Oncology, Dr. Bita Ismaili actually presented the immune checkpoint inhibitors even in Merkel cell carcinoma, where we are going more conservative in preventing systemic metastasis and local recurrence. Now, another thing is we have always heard about sentinel and lymph node biopsy in eyelid and conjunctival tumors, and it is controversial still, but we actually recently has shifted again to using, PET scan in these patients where a sebaceous gland carcinoma is more than 10 millimeters in cutaneous eyelid melanomas and Merkel cell carcinoma of any size as a baseline evaluation, or to evaluate, local lymph node spread and systemic metastasis. So these are the cutting it short. These are the advances, which is not really recent. It has been there, but there are certain things which are still not, entered our country, India, as an ocular oncology. And I'm sure future is promising, and we will be having availability of all these drugs to be more conservative and eye preserving, organ preserving, and vision preserving. So this is one of the book that we have spoken about eyelid tumors in surgical ophthalmic oncology in various techniques of eyelid tumor management. Please go through that. So to conclude, definitely when it comes to malignant tumors or even aggressive other tumors, oncological principles has to be followed. In terms of life salvage, the rule is the same. You salvage the life, then you try to salvage the organ and the vision. So surgical protocols definitely reduces recurrence, and there are adjuvant treatment as in these situations that I highlighted here, where you can kind of use it as an adjuvant treatment in reducing and recurrence and metastasis to improve the outcome in these patients. So as far as advancement is concerned, well, we are reaching to a point where with conservative management, we are salvaging more eyes and vision. There are lots of intralesional injection that we are using and currently in use, and we are experimenting many more. Chemo reduction definitely helps in these cases with various molecular targeted therapy and otherwise. Thank you so much for your patient listening.
Thank you, Feroz, for showing us a very nice presentation and highlighting all the game changers in targeted therapy in oncology, especially to salvage the eyesight and also the life. Dr. Usha, you have extensive experience in oncology. Would you like to add something, followed by Dr. Lakshmi, ma'am? Usha,
Ma'am, mic is off, ma'am. Usha, ma'am, mic is off.
Yeah. I think Kasturi, Dr. Feroz has very well covered all the aspects, and we follow all these principles. I just want to know what is the cost of Mohs micrographic surgery at your center, Dr. Feroz, and how much does the patient have to pay for it?
Ma'am, I'm not a Mohs micrographic surgeon, so I don't do Mohs. I do frozen section.
But you were
I'm
saying
not trained in Mohs.
Okay,
Yeah,
okay.
it's the available technique.
I think it's a costly thing. So patients in our set, even frozen section works well. And we have been doing that for many years. So I don't see any problem with that.
Yeah, but there is always, whenever I talk about frozen section, especially when we are in international platforms, people are more keen on, the debate of Mohs always comes up. So definitely it is one of the option where Mohs surgeons are available. And mainly I think for basal cell carcinoma, they consider it really, really important because base is also important for us, when it's a full lid thickness excision biopsy, we mostly consider margin. But when it's a basal cell carcinoma, it's an anterior lamellar lesion and it's more of a base clearance. So that's what, it's always said that most micrographic surgery with a Mohs surgeon is advantageous than a frozen section.
But there is a study where they've compared both and they found the results equivocal. So it's
Yeah.
good.
Yes, ma'am. I agree.
Yeah, I'm yet to come across anybody who does Mohs. I don't know any Mohs surgeon in India as yet. I don't know. It'll be nice to circulate in our groups to know if there are anybody who's doing it. Thank you, Fairuz, for all the other advancements which you have highlighted, and I'm sure vision conservation and eyeball conservation is the key, and that's very well highlighted in your talk. Next, I call upon Kasturi to give her talk.
Thank you, ma'am.
If there is one word if we have to use for Kasturi, it's just superstar. There's no other introduction I can give. She's an excellent surgeon, teacher. She's built everything, not only in oculoplasty, she does excellent cataract surgeries as well. So can you imagine the whole of Northeast, she has projected so well. She's going to be the incoming president of OPI, and she's already the president of APSOPERS. We're extremely proud of her, and let's hear her now. Thank you.
Thank you, ma'am, for the kind words. So I'll be speaking like something. Oh, my slides are not moving. Okay. So I'll be speaking basically the art of eyelid reconstruction, balancing the function, aesthetic, and precision. So this is something very important. We need to balance, give a big balance of both the functional outcome and the aesthetic outcome in order to have an optical outcome. So when we talk about the eyelid defects, the defects can be both congenital and the acquired. And the common congenital defects of the eyelids are number one, the cryptophthalmos, that we have ablepharon, microblepharon, ankyloblepharon, and the lid colobomas. Cryptophthalmos are very challenging because they're very restrictive pathology. A single surgery does not help. But if we need to have patience in dealing with this patient, like in this child, you can see she's using the torch as an entoptic phenomenon, which is showing that she has some vision after doing a multiple stage surgery. So micro and the ankyloblepharon is not very common, but when we do get, we need to increase the blepharophimotic, the small palpable fissure. So for which you need to do a very good lateral cantoplasty and also a lateral conjunctivoplasty. For children having eyelid colobomas, I always feel that lid sharing should never be done in children because you don't want this child to develop amblyopia. So the best way in such situation is always to do a lateral advancement where you can reconstruct the lid very well, and at the same sitting, you can also give them the vision without making them develop amblyopia. A child may come like he has already developed. You can see the epithelial defect here. So this is just a 1-month-old child, and I had done a lateral advancement. It is easier in the children because you can really mobilize the skin well, and this really gives the adequate correction. And this is one of the best way of managing lid coloboma in the children, where what my previous speaker has mentioned, we need to also take care not only the eye, but also the sight. Another common abnormality which can occur as a congenital eyelid lesion is the Ptosis defect, where we see the soft tissue defect is always associated with a bony defect. So in this situation, we need to manage both the soft tissue and we need to manage the bony defect. Then only you get an optimal result. So children like this, these are all very restrictive pathology. I work with Mission Smile, and these are some of our patients where a multiple surgery has been done both by me and the plastic surgeon, and ultimately we could put a prosthesis in such situation. So this patient, if we look, he has got the Ptosis 3 and 4, and if you look to the CT scan, you see that he has been totally deficient. There's hardly any maxilla. This is a zygoma here, And this is a bony defect. So such situation, we need not only correct the bony defect, we have to also mobilize whatever flaps and graft is possible, because we need to cover this big defect of bone, both the bone and the soft tissue. So the first is what we do, we try to remove all this restrictive pathology, all the scar tissue. And then what I have done a very big tensile, and I had done a lid reconstruction. So after removing all the scar tissue, a tensile has been fashioned, and following the tensile, now my next plan is how to cover the bony defect. So this is how we suture, like the lid margins are being sutured, and then you form the canthus. Canthal forming is a very important step. Like you should always go for the buried suture in order to form the lateral canthus. You should not go for direct apposition of the tissue in order to form the lateral canthus. Otherwise, you will not get a very good alignment of both the upper and lower lid. Then you need to harvest the bone, the bone, hip bone can be taken, and you can do a very good, bone graft out here. And the advantage of this is a autologous tissue, and so the chance of acceptance is much better. Other way is that you can also put a titanium plate, or you can also put a patient-specific implant. So the whatever bone that has been harvested and the tissue covering this bone, that is the dermis and the fat that has been harvested, it has been used to form a soft tissue coverage. But I need to give some blood supply. So I'm using a nasolabial flap to be a source of the blood supply to this soft tissue, that is dermis fat. And then with the mobilization of this, and the nasolabial flap are really good, because if you look to the branches of facial artery and the angiosomes that we have to face, which really helps in a very good tissue viability when you have a nasolabial flap. So the results are comparatively okay. But what I believe that in such congenital eyelid lesion is need a single surgery will not do. You need multiple surgery most often because of the restrictive pathology. When we talk about the eyelid reconstruction in trauma or tumor, we definitely follow some algorithm. And this can be either, it is usually width-based, which can be either a horizontal width-based or a vertical width-based, algorithm that we follow. But a small, just in very simple words, if it is small, we can go for primary closure, or we can go with cantotomic cantolysis, or we can go for the grafts and the flap. So, but what we need to remember that in such reconstruction, we need to replace like for like tissue. So this is the dictum that a graft can be laid on a flap, and a vice versa. A flap can be laid on a flap, but a graft cannot be laid on another graft, but it must be circumvented by the use of sandwich flap, so that the blood supply is given to the graft. The flaps have multiple advantages, like has a blood supply, takes a better color, it can is more adaptable to the weight bearing area. So these are some of the advantages of flap over the graft. But what we need to remember is that this paper is something, an excellent paper, where they have shown that if the graft is approximately, the flap is 3 centimeter, then the tissue perfusion goes only up to 80%. And when the graft, that is when the flap that is being harvested, maximum rotation you can do 90%. But if you go a rotation, like this is the flap that has been harvested, and you reverse it, that is 180-degree reversion, then it is very difficult for that flap to be viable. So in simple, when we do eyelid reconstruction, it's the reconstruction of anterior lamellae, posterior lamellae, of the full thickness lamellae. So anterior lamellae is best done with direct closure or Z-plasty or the skin graft that all of us are doing. And the posterior lamellae is best managed either with a buccal mucosa or a lip mucosa. And especially when you need to correct both the tarsus and the conjunctiva, the best is when you harvest, like this is me harvesting the hard pellet graft, and this is the best way of harvesting, because you have both the mucosal side and also you get some amount of to replace it as a tarsus. So this is how we do a posterior lamellae reconstruction. And when you have a full thickness defect, you can go for direct closure. You can go for lateral advancement. I feel this lateral advancement flap is a wonderful surgical technique. You can really correct up to 50% of the defect if you do it in the elderly patient, if the tissue is a little less. So it's very important. You need to see how much amount of advancement you do based on what is the width of the defect. So this is a wonderful surgery which all of us are doing as a part of a upper lid reconstruction, which can be done in tumor cases, in trauma cases, but this is one of the very simple and also a very forgiving surgery and really heals up very well. But when we have a larger defect, many of us, when we do a bigger defect, especially in the upper lid, we do a cutler beard. That means we take the tissue, the lower lid tissue, and try to fill up the gap. But here the only problem is that you do not have the tarsus. You take the orbicularis, you take the skin, you take the conjunctiva, but you don't have the tarsus. So you need something to form the tarsus. Like this lady, you can see a very big tumor out here. And then we have removed the whole of the tumor, and definitely all has been done under frozen section. Then what I do to form the tarsus, I usually take the tarso-conjunctival graft from the other eye. And this type of graft really gives you a very good lid reconstruction. So once you do take the tarso-conjunctival graft from the other side, and also you fashion the tissue of the lower lid, the skin, the orbicular, and being a sebaceous, we need to do a map biopsy. And this is the graph which we are using for the other side. Then suture the conjunctiva of both the lower lid and the remaining upper lid to the graph. And then the most important, identify the LPS, the levator muscle, and suture it to the graph. It really gives a very good lid crease and also a good correction. And it almost gives as good a normal lid. So after the end of the closure, you need to close in layers, the muscle to muscle and skin to skin. And the excess amount of the dog ear out here, it needs to be excised. So this is what you can see so beautifully. I have used the tarso-conjunctival graft to the other eye, and you can see a beautiful lid crease and also. And this is under the patient. Like this patient, very recently I had done last week. And if we really look to her, this is really a very big tumor involving the whole of the lid. So ultimately, when we were doing the frozen section, we have found that we had to almost excise almost 90 to 95% of the lid. And this is the whole tumor being excised. And if you look closely, this squamous cell carcinoma, you can also see the conjunctiva has also been involved. So we had to remove the conjunctiva scrape of because we wanted to salvage the eye of the patient, had given intraoperative mitomycin because no point we can give interferon, there was hardly any conjunctiva. So then the conjunctival surface has been formed with this amniotic membrane graft. And the same way, I have taken the hard pellet graft from the other side, and this is how you fashion the hard pellet. You take the 4 millimeter of the hard pellet, the tarso-conjunctival graft from the other side, the 4 millimeter of the superior end, and then this tarso-conjunctival graft will help you form the posterior lamellae of this, defective upper lid. So this is then what you do, you suture the conjunctiva from both the upper and lower, then expose the LPS muscle. And this is the LPS muscle that you can see here. And this LPS muscle is directly sutured to the tarsus. So here I'm not doing lid sharing. And many times I don't like to do lid sharing, especially in cancer cases, because I have seen in my 20 years experience, 4 cases where lid sharing was done elsewhere. The tumor has spread, especially a squamous cell carcinoma, the tumor has spread from the upper lid to the lower lid. So most of the cases, especially unless and if I'm sure it's a squamous cell carcinoma, I never do a lid sharing. I try to do something like a lateral advancement and also harvest the tarso-conjunctival graft from the other side. So what I'm doing, you have seen now I have mobilized the tissue, and then the tightened tissue, which is just below I have just released that part, and I have used a skin graft in order to fill up this tissue. And this is the lady which I have operated just last week at the end of the surgery. So many a times we use the freak flaps, and many a times we come to such a situation that we end up almost cutting the whole of the lid. So there you need to form the posterior lamella by the tarso-conjunctival graft of the other eye, and then a flap, forehead flap, or a surrounding tissue flap. This is another case where you can see the involving the whole of the lid. And here I have used a sclera to form the posterior lamellae. So these are different ways of doing a lid reconstruction in the upper lid, but for the lower lid, we like doing a Hughes flap where we take a tarso-conjunctival from the upper lid in case it is not a squamous cell carcinoma. And then you can usually mobilize this tissue, or you can also give a graft since this is a flap. And then you separate it, and it gives a very good function and a cosmetic correction. So these are different ways. Like this gentleman, you can see the whole upper and lower eyelid has been involved. So I have used the flap from both the glabella, and also I have used the Frick's flap. And this is the periosteum that I have used, split it into 2, which is now forming the posterior lamella. And this is being covered by the different skin flaps. And also sometimes we need to do mustard. But what I have realized in my practice that in traumatic eyelid reconstruction, we need to follow a more customized approach because every case has a different challenge, and all this correction depends upon the extent of injury, what is the tissue being available, and the functional and aesthetic consideration. Like this patient, when you see here, like you can see the whole lid has lacerated and everything has gone. His canaliculus, everything has gone. The conjunctiva was absent, so we had to use amniotic mermaid to form the conjunctival tissue. And again, the lateral advancement has been done. And this is at the end of the surgery where this lid we can convert to a much better aligned eyelid. This type of thermal injury is extremely sad, especially when you have something like though this is a first degree, but here you can see almost a second or a third degree burn. So here we need to use a full thickness skin graft in order to go for a good lid reconstruction under gentle window skin, full thickness skin graft. But when you have patient like this, you can see there's so much. And when you know, in case of a burn, what happens? It usually contracture occurs in the flexion side. So there was a contracture. This lady was not being able to move her neck. And you can see some this operation was done elsewhere, where a dermis fat was being given here. And you can see all the scar here. So this is the whole of the contractile tissue that we have removed. That is the whole of this part. And I'll show a small video of this lady. This is also a very recently done. It's really sad to see this type of patient because she had multiple surgery elsewhere. But when she came to me, this was the area of the dermis fat graft. And then what I have done, I tried to release as much of the contractile tissue as possible. And I wanted more of the bleeding to occur. And this is from the lower lid and upper lid, all the contractile tissue has been removed. Now, what I want, I need loss of tissue. And I feel that in such type of thermal burn, especially for the lid, the full thickness skin graft is much better. Here, I'm also doing a LTS in order to give a good shape to the lower lid. And following the LTS, I have, and also there was tarsal eversion. I have done the tarsal inverting suture. And you can see my fellow taking a post-auricular skin graft, but this is not sufficient. I have used PRF because there was so much of contrast. There was no blood supply much. So this PRF, I feel many times I use for many of my fracture patients and also for my burn skin graft patient. It really gives a very good acceptance of the graft, followed by multiple needling. So that is till today, I don't remember, losing any of my graft because I use PRF and I do multiple stage of needling. Then I have also taken my fellow, she had taken a supraclavicular graft here when I was working on the other side. And this we have used for the upper lid reconstruction. And this you can see the whole of the contractile tissue that has been removed. This is a third degree burn. The whole of the skin has been gone. And below you can see some areas of the supraocular tissue, and also the smash can almost be seen here. So the whole of this contractile tissue has been removed, and for that you need a much, bigger graft. But what I have seen in the face, the split thickness skin graft really works good. So we have harvested a split thickness skin graft, as you can see here. This is a graft that has been harvested, and this has been used for the whole of this neck and the face region, along with the full thickness, and some part of split thickness was also given in the upper lid out here because there was deficient of the full thickness. And this is after putting the quilting suture and the bolster. And this was also done very recently. This is, I think, on the this is on the 5th day. We do not remove any of these bolsters and a patch for 5 days. So this is on the 5th day. And this is approximately around 8 to 10 days. And this is now, what the advantage is that she can open her eyes well, and she can also flex the neck. So I feel that eyelid reconstruction really demand a very meticulous balance of function and aesthetic recovery. But the most important thing that you should have a very thorough understanding of the anatomy and the mastery of the surgical techniques. With this, I conclude. Thank you all very much for the patient hearing.
Thank you, Kasturi. That was really exhaustive, and it shows your tenacity and your liking for adventurous. You're moving into other areas also other than the orbit. So this is really amazing, and I think there's lots to learn from you, and excellent work. So, and I think this is really good. So we can. Any comments, Dr. Lakshmi?
Versatile, excellent. Large jawab, I would say.
Tell me, Kasturi, you didn't take the help of any plastic surgeon or anybody?
Sure. Even yesterday, when I was reading the American Academy of Ophthalmology and the Kansky series, we have got so much of responsibility. Just see what are there. We need to know so many things. Bone graft, skin graft. I have learned from the plastic surgeon. Definitely, that is what we have learned. And in fact, out of the way, I'm telling something. I was shocked in Kansky that we are supposed to do peeling. We are supposed to do thread. All these things are there in our textbook, in American Academy book, like lasers. These are all within a curriculum. We are supposed to teach our residents. So now oculoplasty has become something, but the most important thing, we need to learn from other specialty. When I was first doing my straight thickness skin graft, I have learned from a plastic surgeon. Even today, if I have any issue, I'll call the plastic surgeon. But now, after doing multiple cases, I can do my own, grafting. Likewise, even when I started my grafting, rib cartilage, I have learned from a OMFS. I have learned from him, but now I can do it. So that is how we have to learn from each other. But if you now again, I'm going back, I'm studying Kansky and AO series to actually know what is there in the course and how do I teach my residents and fellows.
So this learning is a lifelong process for even the experts. So
Exactly.
I think,
Even now, I feel that I need to learn so many things in my life.
yeah, so do all of us. So that's really nice. So I
Now,
think it's,
I have a very
I'm sure you're
interesting.
inspiring a lot of youngsters over here. And I think we can, Dr. Lakshmi, can we move on to the next
Sure,
talk?
sure. Like,
Yes,
we are
yes.
all
we should.
waiting
I
for
think we're
this talk.
slightly behind time.
This is by Dr. Mariam.
Yes.
Dr. Marian Polly, and she'll be talking on dynamic eyelid reconstruction, breathing life into static structures. Dr. Marian, please.
Yeah, thank you so much, madam. At also, let me thank Dr. Prashant, Dr. Kasturi, and the whole ARC team for giving me this opportunity. Hope my slides are visible and I'm audible. So today I'm going to speak about dynamic eyelid reconstruction. Just now we have heard a very excellent talk regarding the static lid reconstruction from Dr. Kasturi ma'am. So in this talk, no financial interest and consent for photography has been obtained. As we know, eyelid is the most dynamic structure of the face in terms of blinking. It blinks 16 to 18 times in a minute. So this restoring the blink is an essential part for all ophthalmologists. So what happens in facial palsy? We know there is lag of thermos, which can lead to exposure keratopathy, and you can get reduced blink reflex, as well as the lacrimal pump can be defective, which can lead to epiphora also. So traditionally, facial palsy has been corrected with static procedures like retract to release, middle canthoplasty, lateral tasseraphy, lateral canthoplasty, etc. Then later, dynamic procedures has come, and some of the cases needs combination of both static as well as dynamic procedures. So if you think about the dynamic procedures in the management of facial palsy, basically muscle transfers and nerve transfers play an important role. So in this talk, I concentrate mainly on the muscle transfer. So this is the one which I have started doing now, that is orbicularis oculi muscle transfer, where orbicularis oculi muscle from the healthy side has been transferred to the paralyzed side, and I will show a brief video. Surgery is done under local anesthesia. Lid crease incision is done. So there is a dissection done in the subcutaneous plane to separate the orbicularis, both the pre-tarsal as well as the preseptal. The dissection has to be very careful because this flap is very, very important. Reach up to the lateral canthus and then lift the muscle flap. In the pre-tarsal region, up to 2 millimeter has been taken. So when you take out the flap from the septum, take care not to injure the septum. So now the flap has been raised, but keep a base at the middle canthus. So now 2 incisions are made above the middle canthus on both sides. of around 10 millimeters and make a tunnel. So through this tunnel, if there is difficulty, you can put a small incision at the root of the nose, and through this tunnel, the flap is transferred from the normal side to the paralyzed side. So now the flap has come to the paralyzed side. So now once the flap is come, divide the flap into two, upper half and the lower half. Here also we should be very careful, don't manipulate too much and don't cut through also, so that and then after making into two halves, you can put some side cuts so that it increases the length of the flap. So after that, there are some small incisions are made near the lid, lash line where the muscle of rheolon is situated, and attach the flap to this pre-tarsal orbicularis or muscle of rheolon with the absorbable sutures. So here I have made two skin incisions in the upper lid as well as in the lower lid. The same procedure has to be repeated. Then skin incision is closed again with absorbable sutures. Same thing has been done in the lower lid also. And after that, a suture tarsography has been done and eye has been bandaged for 5 days. The other eye is closed with sutures. So after the procedure, we will review the patient on 1 week, then 6 weeks, 3 months, and then yearly thereafter. So these are few of my experience. Like this was a 45-year-old female, schwannoma excision nearly 20 years back. She primarily came for her constant watering due to the reduced lacrimal pump. So in this case, I combined both static, that is, I have released upper lid retractor, lower lid retractors, and then muscle plug also has been done. So this is a post-operative result. There is this was a pre-operative, this is improvement in lag of thymus, and there's an improvement in the retraction also. So now if you look at her video, so you can see there is an improvement in the blink. She was very young, so the blink was very good, and there is an improvement in lag of thymus. So this is another case, again schwannoma excision. She already had a tarsography in the past. Again underwent the same procedure. Pre-operatively, this was a lag of thymus. Post-operatively, there is a residual retraction is still there, but there is an improvement in lag of thymus. And if you listen to her, she speaks in Malayalam, but just look at her blink. So the blink, even though it is there, it is partial. So this is another patient which I would like to share. I saw her in 2019 for the same thing. That at that time I did upper lid retractor release, lower lid retractor release, and she was pretty all right for quite some time. So this was her 2019 photo, and this is her 2024 photograph, like last year. So this is like after 5 years, more or less, the picture is the same. So in this case, I combined with muscle transfer and a major canthoplasty. And this is a post-operative picture with improvement in lag of thymus. This is just 6 weeks photograph, but she has considerably improved. This is another gentleman which I operated after 1 year of facial palsy. He combining both static and dynamic. I did brow lift, retractor release. He had ectropion. I did a tarsal strip. Then he had an anterior lamellar deficiency, so I did a small skin graft also, and combined with orbicularis oculi muscle transfer. And he did well, and he's still under a follow-up. This is a 3 months follow-up, and he's doing well. So now look at it. This is his pre-operative video. If you look, you can see it. There is a transient faint blink is there. This is his pre-op. So now look at this post-op. Just look at his blink in the right eye. So we have assessed, we have documented this with the help of LipiView also. So in the right eye, he had partial blinks, all 14 blinks were partial. In the normal eye, he had 17 blinks, of which 5 were partial blinks. So history, this is not a new procedure. It's already documented in the literature by Hamad et al. In the Journal of Facial Plastic Surgery. And again in Orbit journal, they have documented with the help of an EMG evidence. But in this, they have transferred the muscle only to the upper eyelid. So what's anatomical significance? Superficial buccal band supplies to the medial aspect. And when you transfer the flap, this nerve supply is retained, and which helps in giving the nerve supply to the paralyzed side. So it readapts to the paralyzed motor neurons by changes on the muscle surface, formation of neuromuscular junctions, and as well as biochemical alterations. In short, it gives motor neurotization of the orbicularis oculi muscle. So how it is different from other dynamic procedures? We know temporalis muscle transfer has been in work for quite long time, but here it is mainly based on a voluntary stimulus, that is chewing. When the patient chews, the lid will close. But here there is a persistent nocturnal lag of ophthalmos, and the blink restoration is very less. Similarly, nerve grafts and nerve transfers have also been practiced in the management of facial palsy, mainly by facial plastic surgeons, as well as facial palsy surgeons itself is a specialty group. Again, it is different from crossed facial nerve graft. We need lots of microsurgical cells, long duration of surgery, as well as a long recovery time. So to conclude, even though orbicularis oculi muscle transfer is a dynamic procedure, it restores the blink, but to my experience, it restores the blink partially, not up to the full extent of the other eye. And the main thing is it improves the persistent symptoms of watering as well as ocular surface irritation, so that the patients are absolutely asymptomatic, even though there is a mild residual lag of ophthalmos persisting. So thank you so much for the opportunity. Thank you.
Thank you, Marian, for the excellent talk and for your amazing work. I really feel that this is really a good solution to the lag of ophthalmos, because in spite of giving the gold weight, sometimes the gold weight exposes. Since you're using the autologous tissue and that to the buccal nerve being, transferred to the other group of muscle, it is giving a good blink. I think we all should try this technique along with sometimes a lower lid correction, which we do with the fascia lata, and we do a sling and give a very good lower lid correction. So thank you very much. So next we'll go to Dr. Saurav Kamal, who has been doing extensive work, especially on dacryology, mainly his work on endoscopic cystectomy. Let me see, 1 minute. I missed your slide somewhere. Just give me 1 minute. I have your introduction slide somewhere. Wait. Yeah, I got it. So Dr. Saurav Kamal is a consultant of plastic surgery, dacryology, and ocular oncology at Faridabad Eye Hub Institute. And he has graduated from Maulana Azad Medical College and senior residency from Guru Nanak Eye Center, long-term fellowship in oculoplasty at LV Prasad Eye Institute, Hyderabad. He has 50 publications in peer-reviewed national and international journal, many scientific presentations, a great surgeon and a great, had contributed very much, especially in the field of dacryology. He has received numerous awards, including the AIOS IGO Silver Award, and also keen interest is in pediatric and adult lacrimal and orbital disease. So I have heard you speaking before, and also I have seen your work. I'm really very impressed about the good work that you're doing. And thank you so much for joining us today, and we look forward to your talk.
Thank you, Dr. Kasturi, for giving me this topic, which is very close to my heart. So I also thank the ARC team, Dr. Prashant, and our chairperson, Dr. Usha Singh and Dr. Lakshmi Mahesh. So my topic is my screen visible?
Yes, yes.
Yeah, I go to the full screen. The modern lacrimal surgery, it has evolved over the last century, especially due to the advances in the microsurgical techniques, instrumentation, and endoscopy viewing system. And also the imaging of the lacrimal system has been improved because of the doing the anterior segment OCT, CT, DCG, and the navigation guided stereotactic surgery. So in this talk, I'll be sharing some interesting, I will say, they are the common lacrimal clinical cases. And as we go through them, we'll see the changing management in the current times. So this case, this child was a 4.5 years old, previously had probing twice, which has failed, and now presented with acute necrocystitis. So now the treatment, the current treatment of choice is the nasal endoscopic guided probing. And in this case, as we do the probing and we see the endoscope through, we can see the probe coming, and there was a cyst present inside the nose, which was marsupialized in a cruciate manner. So drainage of this cyst was a corresponding to the drainage of an abscess, which you saw in the clinical photograph from the outside. And this patient did very well. He was asymptomatic and did not require DCR surgery. This is a second child, 5-year-old, older child with the failed probing thrice. You can see the fluorescent dye disappearance test positive. And on the nasal endoscopy guided syringing probing, you can see the probe is even on repeated attempts was moving beneath the submucosa, and this was suggestive of a buried probe. So important in this buried probe is to enlarge this or bisect this tissue with the continuous up and down movements and tilting of the probe so that you create an enlarged opening. And similarly, this child was asymptomatic at last follow-up. So understanding of CNLU, especially, we all know this diagram from the Jones, which has been there in our test book. And the understanding of these variants of CNLU have involved. In the green circle is the simple CNLU and others are the complex CNLU. So nasal endoscopy helps us in understanding the etiology of the CNLDO and in the proper treatment. And even in cases of complex CNLDO with a mean age of 45 months, that is between 3 to 4 years of age, the syringing probing along with the nasal endoscopy and some adjunctives can provide you an anatomical and a functional success rate of more than 50%. So this case, this child is a 3 weeks old presenting with acute necrocystitis with a dacryoceal, and there was a presentation since 10 days. So these dacryoceal cases are important because they have the intranasal cysts, which can be small, which are classified as occupying less than 50% of the nasal cavity, which are completely under the inferior turbinate, or maybe the large, which are occupying more than 50% of the nasal cavity, and they are seen usually without the medialization of inferior turbinate. The importance is that the large intranasal cysts, they can cause the respiratory distress, and hence, especially when they are bilateral, which can these nasal cysts can be seen easily on the anterior rhinoscopy. They should be managed immediately because they can cause a respiratory distress. So usually the conservative approach is followed, but if the child presents with an acute necrocystitis, and especially these large bilateral intranasal cysts are there or anterior rhinoscopy, we should proceed with the nasal endoscopy guided syringing probing. So this is how an example of a case again of an intranasal cyst in a dacryoceal. So you see a cyst there, and even on the probe coming, there was no pus drainage. But as we incise, we give a first incision horizontal with a sickle knife. You can see the pus coming, draining into the nose. And then we give the second incision vertically, which is perpendicular to it, so that you open the entire cyst, marsupialized, and perform a 45-degree probe test, which is basically moving up and down so that to check the cyst has been properly opened. Now coming on to this case, 34 years old male having a bilateral epiphora since childhood, and he was left alone as a punctal agenesis. So on careful slit lamp examination under high magnification, you can see that on the right side, there was some punctum visible, and on the left side, there was a membrane which was occupying the lower punctum. So this thing was there in both the upper and the lower punctum. And in the lower punctum on the right side, this gentleman had what is called the incomplete punctal canalization of internal variant. And this is of the external variant where you do not see a punctum mound, but a whitish membrane which is there. So this was described by Dr. Javed in a paper in 2015. And this is an important masquerade of punctal agenesis as well as CNLDO. So this is another case. You see the internal variant of IPC, and this is easily can be differentiated from agenesis if you further do the anterior segment OCT. So this is the image. You can see the cross section through the lower punctum. You see a bridge, a band of a tissue over the vertical canaliculus, both on the bilateral side. So this is the internal punctum membrane or the incomplete punctal canalization. So if you diagnose them, the management is very important, and they just require membranotomy. They do not even require mini-Minoka. You should do the irrigation on table, and this is the approach which is followed. You localize the lower punctum, the membrane, and we perforate with a slow taper punctum dilator. So this is how we bend the 90-degree, go into the proximal canaliculus. So there may be some form of a variation in the membrane that you may either perforate it completely, or you may create some flaps which may be incentric or concentric. And these residual flaps should be carefully removed with a Vanna scissor. So let's see this case. Another lady, she underwent external DCR. You can see the two scars over the nose, and she was from the Middle East, and she was referred here for the Jones tube because twice the surgery has failed and she did have persistent watering. So be careful. See, we can see the movement of the probe from the upper punctum. There was something moving there. So I did try to explore and revise the DCR. And after the cicatrix release near the common canaliculus, you can see a retained stent there, which was inside. So this is the creation of a lacrimal sac flap. You can see the retained knot now, which was previously not removed properly. And this was then followed by the mitomycin and the intubation. So that patient, she did well after the surgery. Another case, a young case who presented after external DCR with the persistent watering. There was a lack of the sufficient osteotomy. You can see the residual persistent bone, which is in the inferior half of the stack still there. This is the superior half where the bone was removed. And this inferior bone, entire from the sac and LT junction, was needed to be removed. Also, this case has a thick lacrimal bone, which was removed with the drill. So the sac was then completely exposed and open in a book-like fashion. So in acute acrocystitis, especially with the lacrimal abscess, we now prefer percutaneous needle aspiration rather than the traditional skin IND, because that can further scar the lacrimal sac and make the DCR surgery later on difficult. Especially with the endoscopic DCR, it's like doing an IND from inside once we drain the sac like an abscess, and it also prevents the sac fibrosis. Another helpful from is the cases of bilateral nasolacrimal duct obstruction, where I would say it is rather a swap DCR, because you can easily move from one side to the right side while you wait for hemostasis on the other side. So you can also do the external DCR simultaneously, that has been described in the literature, but endoscopic DCR you can simultaneously do, like the ENT surgeon do first on the both sides, and this saves the time and shortens the recovery. So importance of nasal endoscopy also lies in seeing the ostium post-operative, their behavior, how they heal, and also understanding the functional aspect. So this is the normal ostium. You can see the internal common opening, and the fluorescein is freely drilling into the ostium. So this is a good, large, functional ostium. So similarly, if you follow up any case of a DCR, you may come across such abnormalities, like in this case, a large, big ostium granuloma, which requires excision. Because ultimately, if this persists, it is going to fail your DCR surgery. Again, in this patient on routine follow-ups, patient was asymptomatic and syringing was patent, but you can see the lot of an exuberant granulation tissue, which is threatening the your ostium. So you need to step up the both the nasal and topical ostiums, as well as inject the submucosal tricot. This is another case where we can see the silicone tube infection on a normal follow-up, and you can see the fungus infection and also involving the nasal mucosa. So early management removal of this stent, which is now no more needed since the ostium has healed well, is required. So recently also the CT-DCG guided stereotactic surgeries have been described, and they are conducted using the and they are useful for localization of the sac, especially in the saldo. Saldo, that is the secondary acquired lacrimal duct obstruction, and these may be some of the cases where the surgeon who prefers the endoscopic approach may use the CT-DCG, also the navigation system for performing the endoscopic DCR. But especially in the cases if the patient has gross nasal architecture alteration, or if there is an anterolateral displacement of the sac with a telecanthus patient requiring mediocanthoplasty, or if simultaneous fracture repair is needed, or if there is an ill-placed plate or screw, then we still prefer the external DCR. So this was all about the lacrimal surgery, which I think will be helpful to understand that especially about the changing management approach. Thank you.
Thank you, Dr. Saurabh. That was an excellent presentation and lots of learning points. I'm sure the young doctors are really benefited a lot by seeing your beautiful videos. So I think due to we are running late, so we'll go to the next talk by a very young speaker. We have two young speakers with us today. First, Dr. Namita Kumari, who had done her MS from Aligarh, then fellowship in Shroff's Charity Eye Hospital, and working as a consultant oculoplasty and oncology at Dr. Shroff's Charity Eye Hospital, having numerous publications, and also has written book chapters on orbital retinoblastoma, vision, and prosthetic rehabilitation. She is also a reviewer of OPRS and Oman Journal of Ophthalmology, and area of interest being the eyelid and orbital surgery, thyroid eye disease, socket reconstruction, and orbitofacial reconstruction. She is a great surgeon. I have seen her work, and I really I'm looking forward to hear your talk. Dr. Namita, over to you. You're muted. Yeah. You're still muted, Dr. Namita.
Good evening, everyone. Ma'am, am I audible?
Yes.
My screens are visible. My screen is
Yes.
visible. Good evening, everyone. Thank you, Dr. Kasturi, Dr. Prashant, for giving me this wonderful opportunity. Thank you, ARC committee, for having me. And thank you, Usha ma'am and Lakshmi ma'am, for chairing this session, and other speakers for very wonderful talk. So today I will speak on the orbital trauma management and the role of the custom implants and the emerging technologies. So as the incidence of facial fracture is quite high with the recent technology, is around 98 per lakh population, and the ocular injuries are the major part of the facial fracture. Approximately 10 to 30% part of the facial fractures have ocular injuries, and especially when it comes to the mid face area, the 90% mid face injuries have some form of ocular injuries, and incidence of globe removal in orbital fracture is around 6%. So mainly the complex orbitofacial trauma have with ocular involvement have a significant psychosocial impact, and that need to be addressed to get a good functional and cosmetic outcome. So coming to the goals of the orbitofacial reconstruction, first we have to restore the orbital and the facial skeleton. Second is the orbital volume restoration and soft tissue deformity correction. And the final is that to improve the give a good aesthetic and the functional outcome. So this is a common classification, very practical classification given by Dr. Ganga for the simple and complex orbital fractures, and everyone should know about this at least. I am skipping it because of the time. So when it's the consider the restoration of the orbital and the facial skeleton, I found it very similar to the restoration of the house. As in the house, for the restoration, you have to correct the you have to restore the pillars, and also for the similar for the facial skeleton for the restoration, you have to restore the facial buttresses, infra orbital medio orbital stud, that need to be correct. And as for the choice of the material for the house is the depends on the availability, affordability. For also that for orbital reconstructions, the choice of implant is influenced by the various factors like the fracture complexity, the location of the fracture, the surgeon experience, the affordability, and also the availability. So coming to that, what is the for simple orbital fractures, we all are using mainly that titanium prefabricated implants, and that works very well. But when it comes to the complex orbital fractures, there's always debate, should we go for the conventional or the patient specific implant? So let's see that what literature says. So this is one study that systemic review, not only 4-5 studies have been included, and they have highlighted that, of course, that PSI offers advantage, especially for the treating the diplopia. This is another literature we recently published in the Journal of Oral Maxillofacial Surgeons, where they said that PSI offers advantage for the correcting inophthalmos. But this is one study that I found by the Dr. Sanjeev et al., where they have included 11 out of 4,784 studies. This study is basically meta-analysis done under the guidelines of the PRISMA, and they took after that 11 studies in which they found that PSI favors better outcome, especially for the correcting diplopia, inophthalmos, and the shorter operative duration, and for good volume correction. However, in all this forest plot, you can see that the boxes are more in the PSI, but it's not significant because the p-value is not less than 0.05. However, this all favors more for the PSI. So coming for the indication for the patient-specific implant is mainly the complex orbitofacial fractures, especially for the extensive defect, and also for the secondary orbitofacial reconstruction. And as I said that now the orbital has a main component with the 40% of maxillofacial injuries have orbital component. So the benefit of patient-specific implant, it is compatible. It's an excellent matching with the contralateral orbit, and it's a navigation friendly and the radio opaque. However, the limitation is that it requires an intact contralateral orbit, and also the very, very important thing, it requires adequate soft tissue support. And there is because the titanium that is a stiff material, it allows the less intraoperative modifications, and the cost is another factor for the Indian population. So coming to the another is a hybrid PSI implant. What it is done in this, basically the 3D skull model was created using the stereolithographic model and the patient CT scans. So it's very important to know that for the patient specific implant, the slice thickness for the CT scan should be the less than 1 equal to 1 mm. Orbital implant for this hybrid, what we do is like after creating that model, orbital implant actually pre-contoured over this model and then it is used as the intraoperative guides. So this is one case that I want to share because where we corrected, use the patient specific implants. This patient presented to us, 40 years old male, presented to us with a history of 4 years old gunshot injury in which he lost the eye. He has a thysical eye with, you can see that there's this severe enophthalmos with that lower lid ectropion and the extensive scarring in the lateral canthal area, where you can see that skin is very thin. So this is the CT scan of the patient where you can see that there is a like the whole this is the complex orbitofascial fracture involving the whole zygoma, maxilla, lateral orbital rim, and all the floor has been gone. So in this patient, what I feel that for this large complex orbitofascial defect, the PSI would be better choice. So what we did is like we ordered the CT scan for the less than 1 mm thickness, and we get a stereolithographic model, and we get in the contact with the computer designing team. So computer designing team has basically created a 2D two-piece PSI for this patient. Although it was a huge PSI, but we tried to what we did is like we approached this through the previous scar and also the intraoperative route, intraoral route, and we able to manage fix it very well. And we were very happy that we finally placed the implant at correct position, and I sutured it well. But at after post-op day 4 days, what I noticed is that there's a small gap in the latacanthus area. And if you will remember, this is the area where the skin was very thin and fibrous perioperatively. So what is the mistake that happens, that it is like in this area there was not a very good adequate soft tissue support. So I revised this surgery and then we mobilized the flap, and then after that the final outcome after flap reconstruction, it's got a good healing, and this contour is also well. So another material is for this patient specific implant is the polyether ether ketone, that is what we call is a PEEK. So PEEK is a very good material because it has a very inert and biocompatible, and it is very similar to that your cortical bone. And even this has a very malleable property. You can little bit mold on as per the patient need. So on the table, it's the adjustment can be made very easily, and even the drilling is very easily. Putting the screw is very easy. So again, this is another choice for the material, but the cost is something that is around 2 to 3 times compared to if you will talk compared to it from the titanium implant. So again, this is a debatable topic, that which material to choose for the PSI. If should be titanium or it should be the PEEK. Titanium has their own advantage. It is a very good. Otherwise, has a high mechanical strength. Only thing is that there is some thermal sensitivity issue because it has a good conductions. So there's some like patient can complain of that. Feeling the cold and some discomfort in that area, and otherwise it's osteointegrates very well. PEEK has its own advantage, as I mentioned, that it has a very good biomechanical compatibility, and elasticity is very similar to the cortical bone, and intraoperative adaptability is what it makes as a like surgeon's choice. However, the cost is something that is issue with the PEEK, and also there is an incidence of more infection because of the formation of a biofilm over more with the PEEK implant compared to the titanium. But again, need the RCT to for this. So this is this is the one case that I wanted to show. This is the one 2-year-old girl. Basically, she was playing with some gun, and that gun was like monkey gun, they usually call this, to shoot on the monkey, and she accidentally fired it, and that bullet hit into her eye, and you can see that there's a like that bullet in the orbital apical area. So what we did for this case is, uh, the people was well reacting. She was a 2-year-old girl. There's no ROPD perioperatively. We did transcaruncal approach, and we have, through the transcaruncal approach, we have gone to the medial orbit. And after dissecting, you can see that this bullet is lying there, and we just gently catched it with the help of the forceps, and we took it out. So it is around the 5 mm of the bullet, and this is that bullet is basically made of the lead and antimony. So this case is challenging because of the location of the foreign body is in the apical. We all know that orbital apex area is a very narrow space with the very vital structures. So of course we have to explain to the patient that we are doing this surgery, but there is a chance of the vision loss, and that they need to understand. So what there is a role of navigation here, because the navigation will give you the precise location of that, and during that intraoperative it will guide you how intraoperative, it will act as an intraoperative guide, and with it will also provide you the more precision and accuracy. So I think, thank you, Dr. Kasturi ma'am, for sharing this case. This is a very similar case to that girl, but it is a foreign body is in the lateral orbital area, but near to the apex area. And with the help of navigation precisely, you can actually remove that. So this is the navigation stylet that is guiding during the surgery, and this the cylindrical hollow that shows you that the path, that the approach that you have chosen, and this stylet will guide you that during the intraoperative, and with help of that you can actually took out the foreign body very precisely. So that's the role of the navigation. It gives you accuracy, it gives you precision, and of course, the chances of damaging the vital structure is the less. So this is one paper also that advocates for the computer-assisted navigation in the orbital-facial surgery, not only in the trauma, but for the other areas also. But of course, when it comes to the orbital-facial reconstruction, the navigation not just helps you with the giving the precision, it also helps you like putting the where you have to put exactly your implants. So that's the role of the navigation. But of course, it's a cost. It's a financial it's a costly things, and that there is a learning curve for also to have it. So another role of navigation is where is the optic canal decompression, and especially for the traumatic optic neuropathy cases, where actually there is always it has been debatable. Optic in the trauma management, optic canal decompression is a debatable topic. Some people believe that it doesn't have any effect, but if you will see in this case by Dr. Kasturi only, is what two case in this, she has shown that by there is a bony impingement, if you can see in this impinging on the optic nerves, and through again the transcaruncal approach with the help of the navigation, that bony things safely taken out, and the patient in the post-operative period regained the vision from no peel to the counting finger 3 meter. That was reported in this case report. So it is good to have this because it has a role. And there's also some people prefer doing that optic nerve through the transnasal route, and especially the ENT person, that they do that. And that, of course, they in this case series of the 4 patients, they have reported that the 2 patients have actually improved the visual acuity. In this patient, it's improved from the hand movement to 0.03 on the log MR.
Please wind up, Dr. Namita.
Yeah, so what I feel that orbitofacial reconstruction is a multidisciplinary approach. You need a team of a good you need a team. So take home message is that the primary repair in experts' hands always have a best outcome, and teamwork is the key. And timely repair leads to the excellent outcome. Choice of implant still is debatable and is as per the patient needs and the affordability and surgeon choice. And we should have the advanced technology in navigation guided that can be done good for the complex cases for more precise outcome. Thank you.
It was a really very nice talk, and you have covered such a big, topic in so beautifully within this, definitely more than 10 minutes, but very good presentation. Being a very young surgeon, you're doing amazing work. And now we have another young surgeon, Dr. Obedur Rahman. He is an adjunct consultant at the Department of Oculoplasty Oncology at Dr. Shroff's Charitable Eye Hospital. Done his MBBS from Maulana Azad Medical College and then MS from GMC Chandigarh. Fellowship in Ophthalmic Plastic and Reconstructive Surgery and Oculofacial Aesthetics at Sri Shankara Deva Netrada, Guwahati. At a very young age, she has got more than 45 academic publication in some very reputed journal like Orbit Journal, then European Journal, Indian Journal, and also the recipient of the Government of India Award, the International Travel Grant by the Science and Engineering Research. It is very worth mentioning that at this age, he was the chief instructor at American Academy of Ophthalmology for his instruction course on orbital trauma way back in 2022 at Chicago. His non-academic interest is that he is an avid reader, a good writer, and a published author. So over to you, Dr. Ubaid. I really look forward to your topic because I know you're doing extensive work and lots of publication on artificial intelligence. So over to you.
Thank you so much, ma'am, for your kind introduction. And before I begin, I would like to thank the ARC committee, all the members of ARC committee, especially Prashant sir and Kasturi ma'am for providing this opportunity to me. I hope my screen is visible, ma'am.
Yes, we can see Bill.
Okay. Yeah, so I'm Obedur Rahman, and I'll be talking on a very interesting topic, that is the role of artificial intelligence in oculoplasty and how we can glimpse with it into the future. So since the introduction of artificial intelligence in the 1950s, AI has fascinated everyone. And now AI has become a part of our everyday lives. That includes Alexa, Siri, and the social media. And with that, the fascination has increased even more. So what AI has done, AI has created human-like thinking machines which can now think on their own. And an advanced form of AI is deep learning, which can make choices by means of artificially created neural networks, much like the human brain itself. So convoluted neural networks are an architecture of an advanced form of AI that can process data, learn directly from data, and then make choices. So what AI can do, it has the ability to analyze large data sets, whether it is numbers or images, and then make choices based on the training. So since ophthalmology is a technology-driven branch, an image-oriented branch with lots of data, lots of images, ophthalmology can deem great benefit from the use of AI. So what's the role of AI in oculoplasty? If I explain it in very simple terms, what AI does, AI takes an image, extracts features from those images, recognizes patterns, and then makes some choices. If you search on PubMed, you'll find nearly 4,500 research papers on AI in ophthalmology, most of them related to either glaucoma or diabetic retinopathy. But when you look at the numbers in oculoplastic surgery, they are much lesser. So the numbers will be around 30 on AI studies in oculoplasty, but there's still a lot of potential for use of AI in oculoplasty. Why? Because oculoplasty has a lot of external and slit lamp photography, which is not dependent on any high-tech machines, such as a fundus camera or an OCT machine. You just need to have a phone in your hand. Also, oculoplasty uses a lot of scans, be it CT scans, MRIs in the form of 2D or 3D scans, and many other imaging modalities. And with oculoplasty, of course, comes histopathology. So there's a role of AI in histopathology images also. So looking at the role of artificial intelligence in oculoplasty, this is one of the articles that I worked on when I was a fellow under the mentorship of Kasturi ma'am, and we published this in JORP journal. So moving further, and let's see what all the research papers say about use of AI in oculoplasty. So let's start with the periorbita. Since I said that for oculoplasty work, you don't need a lot of sophisticated instruments. You just need an external or a phone camera. So beginning with the periorbita, this particular study, which was published in the American Journal of Ophthalmology, used AI to look at different eyelid and periorbital measurements that included the eyebrow position, the palpebral aperture, the canthal measurements. Now, all these photos were taken by an external camera. So without the use of any human segmentation, AI could definitely find out where the eyebrow is, what are the palpebral aperture heights, and the measurements. Then we move on to the eyelid. Now, this is something on which maximum papers on AI in oculoplasty have been published. So you can see there's a lot of work on ptosis in AI. And on a left hand, the image that you're seeing, that's called a grad cam image, where AI can learn from images and see what's the difference in the different images, and then make choices whether the patient has ptosis or not. So since ptosis is a very common eyelid disorder, which has several causes which can be clinically significant to us, be it neurogenic ptosis or congenital ptosis, since congenital ptosis can cause amblyopia in children. A lot of work on AI in oculoplasty includes ptosis. Also, another thing in ptosis is that there's a lot of subjectivity whenever ptosis is being measured. So my ptosis measurement may differ from another person who's measuring ptosis. What AI can do, if all things are standardized, AI can create objectivity in these measurements. So all the AI studies that I showed earlier that worked on ptosis showed a sensitivity exceeding 90% among the studies. So AI can definitely have a potential for mass screening and early referrals, especially in children who might be prone to amblyopia. Then another thing that AI has been used in oculoplasty is the eyelid tumors. So this is another paper from 2023 that picked up malignant eyelid tumors. Since eyelid tumors have varied presentations, they can be either benign or malignant. Both of them have a lot of mimickers and masquerades and can be sometimes confusing to junior ophthalmologist or maybe comprehensive ophthalmologist. AI can help them in picking up these tumors early. So these are two AI studies that differentiated malignant from benign tumors with a sensitivity that exceeded 90% and an accuracy that exceeded 80% in both of these studies. Also, when the performance of AI was compared to ophthalmologists, it was noted that the performance of AI was just comparable to ophthalmologists. Another interesting study. Now, these are two studies that identified retinoblastoma using AI. One of them is a study by Dr. Kaliki et al. From the LVPI Institute. So these studies had accuracies of 92% and 85% respectively when picking up retinoblastoma. The study, that was the Indian study, it had a sensitivity of 85%. And the interesting thing is for group A retinoblastoma, that is the earliest stage, the sensitivity as well as the specificity was 100%. Another interesting thing that came out from the study that AI could not just detect tumors, it could also detect seeding in the vitreous cavity. So AI was used for classification of retinoblastoma with a sensitivity that ranged from 60 to 100% based on the grouping of retinoblastoma. Then there are radiology-based studies using AI. So there are two studies which have used radiological images. One is for detection of orbital fractures, and the other one tried to detect thyroid eye disease from CT scan images. So these images, studies noted that AI could detect orbital fractures when CT scan images were presented to it with an accuracy of 92%. And while AI looked at orbital structures in CT scan, it could detect thyroid eye disease with an accuracy of 85%. Then there are studies on ocular surface also. This particular study from 2021 used AI to detect conjunctival melanoma and differentiate it from three other mimickers that included conjunctival nevus also. So MobileNet V2 is one of the deep learning algorithms of AI, which was shown to have an accuracy of 87% in this particular study. Now, this particular study to detect ocular surface squamous neoplasia is something that I worked on at my institute. This is from our institute at Shroff. So OSSN we know is the most common conjunctival malignancy in India, and you can capture these images either with a slit lamp or an external camera easily. But the thing is that OSSN needs to be differentiated from other ocular surface lesions such as pingicular pterygium, nevus, scleritis. Some of them can confuse a comprehensive ophthalmologist or maybe PG residents. And sometimes these patients may go home with topical steroids or lubricating eye drops and may present later with an advanced form of disease. So while OSSN is completely treatable by topical chemotherapy in many cases, that is why it is essential to pick up OSSN just at an early stage, because presentation at a late stage may involve radical surgeries. So what we did in our particular study at our institute, we used slit lamp images from the last 10 years, and we created a ternary classification system. So one group contained OSSN images, another group contained other ocular surface diseases that were not OSSN, such as pterygium, pingicula, and the third group was in normal ocular surface images. And then we applied some stringent inclusion criteria, and we distributed all the data equally in the three groups and used three deep learning models. So from our study, what we noted is that AI could detect OSSN from this ternary classification system with an accuracy that ranged from 83 to 89% based on which deep learning algorithm you are applying. So that creates a lot of potential windows for screening of these patients in peripheral centers and maybe primary healthcare centers and early reference. So apart from that, AI has also been used for predictive models. So what these predictive models can help a clinician with is that looking at a picture of a patient when the patient presents to you, you can actually prognosticate a patient and educate the patient that whether the patient may fall in a high risk or a low risk category. So a predictive model was used for basal cell carcinoma that was published in 2017. And AI has also been used in histopathological images. So the second study published in Ocular Surface, what you're seeing on the screen, this particular study used histopath images to detect the clear margin, that is differentiate the tumor histopathology images from the non-tumor area. And AI could successfully do that. So looking at all of the studies and published literature in AI, we need to understand what is the intersection of oculoplasty and artificial intelligence, or let's say ophthalmology in general. So we need to understand that while artificial intelligence has been literally romanticized in recent times in a lot of literature and experiments and research, it is just an aid to the clinician and not a replacement for the clinician. Because the final onus of diagnosis and management always lies on the clinician. So you cannot say this patient is this particular diagnosis or I gave this particular medicine because AI told me to do so. No, the onus lies on the clinician itself. Also, most of these published literature are just research works, and the performance and role of artificial intelligence still needs to be studied in the real world setting. So what's next for AI in oculoplasty? So looking at all these studies, we see that AI does have a great potential in oculoplasty, but we need to collect more data and we need to standardize data. Current studies are regional. So every particular study is from some particular country, some particular area. But the need of the hour is that we need to create global studies with larger data so that we can standardize results. So AI, if applied successfully, definitely has a positive role because it can bridge the eye care gap between tertiary centers and peripheral centers and bring these patients to tertiary centers at an early stage. So look at a future direction where AI may be able to identify, segregate patients, hint at a line of management, and even refer patients just when the patient looks into a camera. So a lot of eye care centers have the EMR systems now where patients' photos are captured when the patient registers themselves. So AI, if used successfully, may be able to segregate them and send them to specialists, especially from peripheral areas where only one photo may send a referral to a tertiary care center. Thank you for your attention and your time.
Thank you, Dr. Obed. It was an excellent presentation and you have covered all the topics so well and really very great learning points for each one of. And I also feel that AI is today one day it will be the ultimate and we should really work on the data and see how do we give back to the community. Especially it will help more in the peripheral centers where even a technician will be able to get a diagnosis and also go for the appropriate referral so that patient treated early best managed and we can salvage both the eyesight and the life. So now I think we'll not go much into discussion. We have the last topic, which is really hot and sizzling. So we have Dr. Prithvi Shetty, who had done his MBBS from CMC Vellore, and then his PG from RP Center, All India Institute of Medical Science, then senior residency in oculoplasty, again from RP Center, All India Institute of Medical Science. So he'll be, giving us some journal articles, and I'm sure that we'll be getting new insights and also get some new knowledge. What is the recent trend going on in oculoplasty? So thanks, Dr. Prithvi, who has done multiple publication, and also he happens to be a very dynamic upcoming oculoplasty surgeon planning to settle well in Bangalore, and he has enough training, enough knowledge, and enough experience. It is always very nice to interact with him. So over to you, Dr. Prithvi.
Thank you, ma'am. Thank you, Kasturi ma'am, for the kind introduction. And also, I'm thankful for the platform for providing me the opportunity. Is the slide visible, ma'am?
No. Yeah, now we can see, but not in full screen.
I'm presenting an interesting case which I came across. This journal article is basically about the injection betamethasone, which is compared with the injection triamcinolone acetate TA in a thyroid eye disease related upper eyelid retraction. This is published recently in the last year. It is a double-blinded randomized RCT conducted in Upper Egypt, which is conducted over a period of 2 years. As we all know, the lid retraction is seen in almost 90% cases of the thyroid eye disease, which is a part of, it is an autoimmune inflammatory condition where in early phase there is expansion of tissue and later there is scarring of the basically orbital fat and the muscle, striated orbital muscle. The proposed mechanism of the lid retraction is basically sympathetic overactivity, which is caused due to thyroid hormonal hypersensitivity of the sympathetic receptors to the adrenergic hormones, which is causing Muller muscle overaction. And also LPS fibers get hypertrophied, and also the fibrosis in the later stage, which also causes lid retraction. And there is a phenomenon called fixation duress, where contracture of the inferior rectus, which is involved in the TED, which is causing the eye to go hypertrophia, due to which the SR-LPS complex get activated, which is causing lid retraction. So if we need to intervene the retraction during the early inflammatory phase, which is reversible. If we don't intervene, then it can progress to a chronic fibrotic irreversible stage where the surgery is required. So what are the available treatment options in the early phase? We can give either systemic steroid or immunosuppressive, or we can give a local steroid to suppress the inflammatory condition. There are studies where showing giving Botox and fillers for the retraction, but in the early phase, this is not tackling the basic pathophysiology and it's also temporary in nature. So systemic steroid can be used, but it has limitations because of infection, diabetes, hypertension, and also can cause systemic side effects. So we are left with the local steroid injection. TA has been used for a while. It is intermediate duration of action, because of which it requires multiple injections. And also the potency is not that great, so it could cause complete reversal is only 60% of cases. Because of all these factors, there was search of drug which can act locally need to be found. Our author found a betamethasone, which is a long-acting synthetic steroid. So because of which less injection may be required. So he also has used the same drug in many of the orbital inflammatory conditions like dacroadenitis and other inflammatory orbital diseases, where he has seen early resolution of the disease and also has achieved long-staying results, which is not recurring. These are the articles by the same author. Because a pilot study initially was done in the dacroadenitis with 5 patients showing early response, and follow-up period of 19 months is showing no recurrence. This is the second study where 47 patients were included, where response was seen within 7 days, and long follow-up period of 8 years showed only 2 recurrent diseases. So why did I choose to discuss? Because it is having a high level of evidence, as it is double-blinded and RCT. And both the injection which is in use, TA, and also the betamethasone is been compared hand-to-hand. And also there is proper outcome analysis, complete reversal if there is MRD1 of less than 4.5, partially reversal, and no response. And also the betamethasone group, we can see 92% patient has complete reversal, even and none of the patient left with any residual disease. And in group 2, where TA was used, you can see only 60% had complete reversal, and almost 18% patient were having residual retraction. These are the pictures of the study patients where retraction is reduced, and also the LPS LPS muscle has been reduced in the bulkiness. So this study was conducted in Egypt after all the study approval and registration over a period of 2 years. It has been randomized into 2 groups. 28 eyes were placed in each group, and it is a double-blinded. Overall blinded, one is the patient and the single ophthalmologist who is recording the MRD1. He's been blinded, not the surgeon who is going to inject the injection. All patients had undergone thin slides of contrast enhanced CT or MRI. Patients were above 18 years who were presenting in early inflammatory phase within 1 year and not having any proptosis and having euthyroid state for last 3 months were included, and the others were excluded. And also the patient having CAS score of more than 4, where maybe requiring steroid and also systemic steroid, and patient who are already on systemic steroid were excluded because this may be a confounding factor for the study. So injection site, they choose to give transcutaneous with a 22 gauge needle. The approach was they choose a central eyelid, upper eyelid, just below the superior orbital rim, where the needle is first introduced towards the roof of the orbit and then parallel to the roof of the orbit. So in injection group, both the groups were given 1 ml of injection. In group A, betamethasone suspension, which is having both the 2 kinds of salts were used. In group B, TA injection was used with a concentration of 40 mg per ml. So injection was repeated if there is improvement in MRD1 for up to 5 injections. It is stopped if the improvement is not seen in 2 consecutive injections. or if the patient is reversed completely. So follow-up was done after every injection. Follow-up was done at first week or fourth week, and after last injection, the follow-up was scheduled at 1, 3, 6 months, and every 6 months thereafter. Outcome, as already been described, this was categorized as effective, which is complete reversal, where MRD1 is less than or equal to 4.5, partially effective if it is improvement is seen but not completely reversed, and ineffective. This is the demographic comparison of the data of both the groups, where you can see gender, age, laterality, CAS score, and duration of TD is seen similar in both the groups. This is the data analysis of MRD1 pre and post injection. You can see in pre-injection the rate retraction in both the groups were almost same, and post injection with the cutoff of 4.5, you can see group 1 the mean retraction is below the cutoff, and the group B it is above the cutoff, and it's also statistically significant difference. And the mean improvement in the retraction is around 3 mm in the group 1 and 2 mm in the group 2. This table is already been discussed in the beginning, where you can see complete reversal in 92% of patient in a group of betamethasone, and in group 2 60% patient had complete reversal, but was that 18% patient did not show any improvement. This table wanted to give some time. Here we can see that in group 1, 40% of patient improved with single injection of betamethasone, and almost 93% patient improved with 2 injections of betamethasone. And in partially effective patient, where 1 injection would have shown some improvement, so they proceeded to give second and third injection, which did not give any improvement. So this indicates that patient who is supposed to improve will improve with 1 or 2 injections, and we may not show any improvement later on. This may be because of partial fibrosis, which is not responding. In group 2, the results are inconsistent, where we can see only 30% improved with 1 injection, then later on with 2 injections, 7% improved, then with third injection, 21% improved. So it is requiring multiple injections, and the response is not expected response. This is the group A pre-post pictures. We can see the retraction of lid, which is completely getting reversed, and imaging of similar patients, where LPS is bulky in the above pictures and which is normalized in the below picture. These are group B patients, where TA was given. We can see outcome is good in few patients, and some patient there is partial reversal. In one patient of group A, there were complete ptosis was noted, which improved spontaneously over 6 weeks of duration. There is no any other complication noted with the injection. Thank you.
Thank you, Dr. Prithvi. That was a very good insight for all of us. Like you have shown, so on actually is the treatment, because from your study I have seen that use of betamethasone 1 ml has given a recovery to almost 93% of patient, and whereas only 50% with the triamcinolone, because most of us are using triamcinolone. But you have shown that this study has shown that betamethasone works better, and the reversal is less. That is what new, that is what I should say. Anyone using betamethasone over here, or all of us are using Tricod? Lakshmi ma'am?
You mean for eyelid retraction, Kasturi?
Yes.
I don't use anything.
Okay. So I feel that in the early stage, I use pure triamcinolone, 40 milligram. But in case it is chronic, I make 50-50, 5 FU with triamcinolone.
You mean
that is what
both and give?
Pardon?
Mix both of them and give?
Yes, 50-50, yeah. I do 50
Mix
like
together.
0.5 and 0.5 together.
Okay.
Together.
When do you give it in the acute stage?
acute, not very acute, but I see that if there is some CAS score is still there, like whether it's a CAS score 1, 2, some redness is there, then I give only steroid. But if there's CAS score is 0, then those are the patients which we give 50-50 steroid plus your 5-FU.
What about what is the trade name of the betamethasone injection you're giving?
Betamethasone I'm not using. I'm only
Trade
Thyroid.
name.
Trade name they have not mentioned in this, no? I'm not sure trade name.
I don't
I'm
know
not,
because
yeah, I have also no experience with betamethasone.
hmm.
Even for eye drops nowadays, it is so difficult to get betamethasone. We all get dexamethasone. There's only one company which has betamethasone, and after that, and that is now the cheapest eye drop, a steroid antibiotic, which is only 9 to 10 rupees, I think so.
Was there when we were students 30 years back, we were getting betnesol eye drops.
And that is what I'm still, it is there. And still, many of us are still using that because we see that betamethasone is the most potent. Like what Dr. Prithvi has mentioned, triamcinolone is 5 times more potent than hydrocortisone. And betamethasone is 30 times more potent. That's why they have found more effectivity in betamethasone number 1, and the recurrence is less. Like 93%.
How long does this last? The effect last?
That is what they said, that almost 100% after 2 injection. Am I right, Prithvi?
Ma'am, complete reversal was seen in almost 93% of patients with 2 injections, and the recurrence was not seen in over a long period of 20 months follow-up they have done.
What is the titration like? How much are you going to give?
Ma'am, in 1 ml of betamethasone, they have a mixture of betamethasone phosphate and acetate. 2 salt is there, where 3 mg and 5 mg. Ma'am?
How much you give? The titration part is also very important.
Overall dose was 1 ml.
They have given 1 ml, 1 ml. What I could understand from this study. And the technique that they have used, that was something very nice. It was directed, it was given in the LPS, but directed to the superior orbital rim. So that I think they wanted some to enter in the SR and LPS complex, right?
Yes, ma'am. 1 centimeter they are directed towards the rim, towards the roof, then they are directed backwards 1.5 centimeter.
No evidence of ptosis in anyone.
1 patient had ptosis, which recovered in 6 weeks spontaneously.
The chances of getting ptosis are more with tricot because it sits like a depot. It's a depot preparation, right? It can even cause a mechanical pressure. I don't know. I'm still very skeptical about. Milind uses a lot of Botox, right, to create some amount of ptosis. He is still using, I don't know, Botox.
We have used tricot. We use tricot frequently for eyelid retraction. We didn't see any ptosis as such.
And you also directed it towards the superior orbital rim?
Yes, ma'am.
I mean the superior orbital wall, that is the roof.
Roof. We breach the septum and deposit on the above the LPS.
That is in the roof. So just like we give a periorbital blocks, you centered it more. Instead of giving it the nasal quadrant,
between LPS and the septum.
Okay.
But what I was doing, I was going transconch, and I used to give into the LPS. So I never used to direct it towards the roof. So this is something new I have learned from your article, that they're going by the anterior approach, where they're directing both on the LPS and also on the roof, so that I think there's some diffusion inside.
Do you withdraw the needle a little bit before injecting the complete?
Yes, ma'am. Definitely, we should check for any intravascular entry into intravascular area.
I'm still skeptical, but I would really like to thank you for bringing about this. It looks very simple, but there's a lot of thought process which goes to this article. First, I thought, what kind of a faltu presentation is he discussing? But as you went and discussed it so beautifully and you made your conclusion and you emphasized the important points. I think there is a food for thought. There is something to think about it and consider.
Thank you.
I don't want to be bullheaded and say, no, I won't. I'll think about it. Thank you so much.
Thank you.
So, Dr. Usha, but anyway, congratulations, Dr. Prithvi. It is really eye-opener because what I
Yeah,
feel,
Prithvi and Obaidur, the youngsters have done very, very well. Both of them, I really congratulate.
all of
Thank
them.
you. Thank you, ma'am.
Nice to see the
I'd
youngsters.
like to
Even Dr. Saurabh is also very young for us. So all the youngsters
So
present
Saurabh
so
I
well.
wanted to tell, but they said paucity of time. If there's one word to describe him now, it's a maverick. He's a maverick.
I'd like to
Thank you,
congratulate
ma'am.
everyone, and especially the youngsters, Dr. Prithvi, Dr. Namita, Dr. Vedur, and of course, everyone else. Thank you so much.
So young. All the
We've
young.
learned a lot today.
It's very nice when we see the young generation coming up with so much knowledge and presenting so well. And also we get some learning points from you all. So thank you each one of you. Especially, I would like to especially thank Lakshmi ma'am and Dr. Usha.
Yeah, I would like to thank the youngsters, Kasturi. I'm really glad you brought about this. And
It is for the first time we are getting all so many young people because I feel that, you know, their way of thinking and they're all like this generation is something different, which I always keep on telling them. They understand, but there's so many things to learn from them, and they're very passionate in their work, and they try to do something new, and they have a logic behind everything. Like even Dr. Ubaid's lecture was amazing. It was really an eye-opener for us. Dr. Namita presented so well, and Mariam as usual. And Dr. Saurabh also for me, he's still in a young generation, and he's one of the best endosurgeon I have seen. I have been seeing his presentation for so many years.
Yeah, consistently he's doing the good work.
And also thanks to a very senior faculty, Dr. Usha Singh, who had brought up so
I totally agree with all the points, Kasturi, which you've said about these youngsters. They're a new generation and very passionate people. And very focused also, very focused.
Very focused. That is what I have seen them. And they want to learn. I know Dr. Prithvi, like I have seen him, like he wants to learn every day. He has a question. The moment I touch something, he will ask me why this and why not. So before starting the surgery, I just look to him and I prepare myself, like how to answer to these young people. But anyways, it's a very nice session. We had 2 hours, how many minutes? 2 hours, almost 2.5 hours. Thank you each one of you for being with us. And I do hope that we have more such session involving more the young people, getting the words of wisdom and learnings from the seniors, and also saying the new global approach to oculoplasty. So thank you very much. Again, on behalf of ARC AIOS, I thank each one of you for spending this evening with us, and especially Dr. Prashant, who is the chairman of AIOS ARC, for giving all the OPI members a platform to showcase their surgeries, their different challenging cases. And congratulations, all of you, and good night to each one of you. Thank you very much.
Thank you and happy New Year.
Thank you so much, ma'am. Good night, everyone.
night, ma'am.
Thank you, everyone.
Thank you.
Thank you, everyone. Thank you, Dr. Lakshmi.
Thank you.
Thank you, Dr. Kasturi, and thank you, Dr. Usha.
Let us take a picture.
Thank you.